Hi, and good afternoon. I am Kim Keebler, the editor-in-chief of the Multiple Chronic Conditions Resource Center, and we are pleased today to invite and hear from Rosa Hart. And I'm going to briefly read her bio. She is a stroke-certified registered nurse with the American Association of Neuroscience Nurses. She's a podcaster and internationally recognized leader in health communication, digital engagement, and nursing innovation. As the founder of Rosa Hart Media Consulting, she helps healthcare organizations, startups, and nonprofits elevate their visibility through strategic storytelling, podcast production, and social media amplification. That's a lot, Rosa. She is the author of Speak Up, Start Now, and that is partly why we are interested in learning more about what you have to do, but also that you deliver keynotes nationwide and empower nurses to use their voice for advocacy, professional influence, and improving community health literacy. Her work sits at the intersection of healthcare, communication, and innovation with a mission to amplify messages of hope and improve quality of life through trusted, evidence-informed content. Very important. She built authority for a leading health system by producing a widely respected neuroscience podcast and now hosts both Nurse Rosa's Insights, Stronger After Stroke, and Aging Like a Pro, where she translates complex medical science into meaningful, accessible conversations that empower patients, caregivers, and clinicians. Meanwhile, she serves on the Next Gen Advisory Council for the American Nurses Association and the Midwest Advocacy of Communication Subcommittee for the American Heart Association. She's a champion for cardiovascular health equity, policy engagement, and the advancement of nursing leadership. Rosa, thank you for all that you do.
Thank you so much, Kim. I appreciate you inviting me here today.
Yeah, absolutely. And one of the reasons I invited you is because of the recent release of the 2026 Guideline for the Early Management of Patients with Acute Ischemic Stroke. These guidelines replaced the 2018-2019 guidelines in the same month, and I think we talked about it, Rosa, the same month, the Centers of Disease Control and Prevention identified the top 5 causes of mortality in the United States and identified stroke as the 5th cause of death in the country. Stroke contributes to over 162,000 deaths annually and accounts for approximately 1 in 6 deaths from cardiovascular disease. It is, as you know, one of the leading causes of long-term disability, occurring in average every 40 seconds. So with that said, Rosa, can you help set the stage for our audience by describing what is meant by time is brain?
Yes, thank you so much for asking, because that's something I say a lot, and I don't want people to think it's just like a slogan or something like that. We say it a lot at the American Association of Neuroscience Nurses. Time is brain, and what we mean by that is just a biological reality. Every minute that a stroke goes untreated, approximately 1.9 million neurons are dying. And that's like 14 billion synaptic connections that are lost every hour of untreated large vessel occlusion. The brain can't wait for rescue. So the phrase time is brain reframes stroke as the neurological emergency that it is, a brain attack. When blood flow is blocked, the brain enters what we call an ischemic penumbra, a zone of damaged but still potentially salvageable tissue surrounding that dead core area of injury. That penumbra is the target of everything we do in acute stroke care. Every intervention we have, from calling 911 to IV thrombolysis to mechanical thrombectomy, is a race to rescue that tissue before it converts to irreversible infarct. And that's why the 2026 American Heart Association, Stroke Association Guideline places such strong emphasis on pre-hospital hospital recognition and system level speed of care. So, key updates that we may talk about include endorsement of mobile stroke units, refining the EMS triage process, expanded use of tenecteplase within 4.5 hours instead of just 3.5 to 4 hours, and a broader eligibility for endovascular thrombectomy, all of which are designed to close that gap between the symptom onset and treatment. And time is not just brain, it is function, independence, and quality of life, preventing that disability that you were talking about.
That's very well defined, and thank you for that. The new guidelines highlight the implementation of new technologies that are aimed at improving stroke recovery, such as the brain-computer interface and increased motor function within the chronic stroke, which you just alluded to. But can you elaborate of what this a little bit on what this means for rehabilitation, and are there any barriers to this recommendation from the guidelines?
Yeah. And this is one of the most exciting frontiers in stroke rehabilitation. The 2026 guidelines inclusion of these technologies signals a significant shift in how we think about recovery, especially for chronic stroke survivors who have traditionally been told that they've plateaued, or however you are at 6 months to a year after stroke is how you can expect to be and have that as your new normal. But exciting technologies like brain-computer interfaces, or which we would abbreviate as BCI, works by detecting the brain's own motor signals, the intention to move, and translating those signals into real-time feedback or actual movement through paired devices. And it could be like a robotic arm or something external like that. But the BCI technology can be used to stimulate and enhance neuroplasticity, which refers to the brain's ability to reorganize and repair itself in response to experience, learning, environmental changes, or injury. Neuroplasticity is a very popular buzzword, but it's not just a buzzword to us in stroke recovery. It is everything. Motor imagery based BCI systems decode cortical activity associated with the patient's motor intention and use it to trigger time locked peripheral functional electrical stimulation, forming what's a closed loop sensory motor circuit. And yes, I do have that written down because that was a mouthful, but I didn't want to say it wrong. So, the synchronous activation of cortical and peripheral pathways in, induces that plasticity, strengthening the corticomuscular connections and promoting that motor recovery. And what this means for rehabilitation is really profound because it's a change from what was the established, understood norms. BCI coupled to functional electrical stimulation has been shown to elicit significant clinically relevant and lasting motor recovery in chronic stroke survivors. And this recovery is associated with quantifiable signatures of functional neuroplasticity, specifically an increase in functional connectivity between those motor areas in the affected hemisphere that correlates with functional improvement. However, barriers remain, as you mentioned. We need long-term usability to be feasible for these people. There are some ethical concerns about, whether or not things are equitable, but also if you're trying these new technologies on people's brains, like what is the risk versus benefit, and technical variability, like the same thing may not always work for different people, but I'm really excited they're trying it. Beyond those, access, cost, and insurance coverage are real world challenges that get in the way. And most patients are not receiving this technology in community hospitals. And even those that are, the workforce training is still catching up to the evidence. But the guideline signals the direction that we can go in, and now those systems will just have to catch up.
Yeah, and I was thinking about, I'm in rural Georgia, and I was thinking about whether or not some of these rural community hospitals have access to these tools.
Well, before these guidelines came out, even at the less rural places, there was questions about, how much evidence is there for these things and those other cost prohibitive things. So we have to start rolling them out somewhere, and then we can have it trickle down.
So, how should or what should healthcare clinicians understand about vagal nerve stimulation, functional electrical stimulation that you mentioned, virtual reality, and home based tools to enhance neuroplasticity and the cognitive motor outcomes that follow in people that experience an ischemic stroke?
Yeah, this is one of my favorite topics because so much of what we focused on in stroke care is that acute phase. And all of this that you just mentioned are things that come into play with chronic stroke, like 6 months after, for example. And clinicians need to understand that these are not experimental extras that would be nice to have, but these are evidence based tools that expand what rehabilitation can look like, especially beyond that inpatient setting, where whether it's when they're initially having their stroke and they're in the hospital for a few days to a couple weeks, or they're in a more long-term rehabilitation setting and then they go home. um, One of my favorites is the vagal nerve stimulation device that has been paired with rehabilitation that increases the upper extremity Fugel-Meyer scores compared to those who are just receiving rehabilitation alone. And that's called Vivastim. It's FDA approved, and it has brought this into clinical reality, like giving people the ability to perform their activities of daily living, whether it's writing a letter to their granddaughter or, you know, taking care of their own needs in the bathroom. Like, that's a huge quality of life impact. And reducing disability for them also reduces additional burden on their caregivers of things they don't have to do for them. And with like the functional electrical stimulation, that delivers more targeted external electrical stimulation to those paretic muscles that have decreased innervation after the stroke, but they're not completely cut off. So it just increases that stimulation to strengthen those connections. And that can assist movement and sends that sensory feedback to the brain, reinforcing those loops. And another one that I'm really excited about is the pharyngeal electrical stimulation that is done so far by Phagenics, and that several studies have demonstrated a reduction in both dysphagia severity and aspiration risk after treatment with that PES in patients with acute stroke. It's applied via nasogastric tube, which I used to put in every day in the ICU. So that doesn't sound like a hard ask for an ICU nurse. Any ICU nurse can drop that in, and it may lessen the risk of pneumonia through improving their airway clearance, having safer swallowing ability, and the ability to eat a more normal diet. PES, that Phagenics device, has been tested in patients with severe stroke who required intubation with mechanical ventilation, and we know that that tends to worsen dysphagia if they're intubated. Obviously, whether or not they had a stroke, but definitely if they had a stroke too. Um, and PES treatment resulted in reduced dysphagia severity, decreased that aspiration risk, and expedited decannulation, or being able to get off that mechanical ventilator in patients with that severe stroke. And something I just noticed today when I was reviewing to answer these questions with you is that has level 2A evidence for that pharyngeal electrical stimulation, and the oral hygiene recommendation that we have based years of practice on, where we got to clean their mouth after stroke to prevent um, aspiration pneumonia, that only has level 2B evidence. And so 2A is more evidence than 2B, which I also, studied up on today. And so it's really interesting to see these things come in, and that's because there's no one way to perform oral hygiene that's had the same level of rigor applied. So I'm not saying it can't be done. But it is really exciting to see that validation that it has a better outcome.
Evolution of care, right?
Mhm.
So, thinking more now about the acute patient, how does patient selection determine reperfusion, such as IV thrombolysis or thrombectomy?
So this comes into patient selection, and our providers have been practicing their best clinical judgment. It's kind of been the Wild West of people trying to see how they can expand care, and all those risks that they have taken have really paid off. So now we have these guidelines to support people who are not as comfortable taking those risks, to let them know, hey, we have seen that this has worked in these criteria. So it's a combination of their clinical judgment, imaging, and the timing. And in the 2026 guidelines, it significantly expanded who can benefit from both thrombolysis and thrombectomy. So, for thrombolysis, the new guidelines endorse the use of either alteplase or tenecteplase. We call those TPA or TNK, and to a 4.5 hour thrombolytic treatment window, meaning if you've had onset of symptoms and it's been less than 4.5 hours, then you may be able to get that thrombolysis IV to break up the clot. But before, it would have been a 3 to 4 hour cutoff. And so now they've expanded it for wake up strokes as well, where it may have been almost 9 hours. But if they can use imaging criteria such as a DWI flare or another perfusion based mismatch scan, they can identify what area of the brain tissue is salvageable. And this is really important for patients with non disabling deficits. For example, if they're having sensory symptoms, they can still move their arm, but they can't feel their arm. Our trials have failed to demonstrate benefit of thrombolysis, and they may recommend that they do dual antiplatelet therapy with like aspirin and Plavix, and that would be preferred versus the risk of the thrombolysis in lower disabling situations. It's all about weighing how much disability is at stake, and the endovascular thrombectomy is now a standard treatment for large vessel occlusion, but the recent evidence supports expanding it to patients with larger ischemic core strokes based on that diagnostic imaging. For example, a class 1 recommendation advises thrombectomy for patients in the anterior circulation presenting 6 to 24 hours after symptom onset. If they're younger than 80, if they have an NIH stroke scale score of 6 or higher, and if they have some other criteria that's outlined. But having that criteria really empowers the clinicians who may not see these scenarios as often to know kind of what's safer to do. And it provides a strong recommendation for that endovascular thrombectomy in patients with basilar artery occlusion, which was debatable, presenting within 24 hours of symptom onset and an NIH stroke scale score of 10 or higher. And um, the the key there is basing these decisions on imaging and knowing that imaging is giving us information that's letting us know more of the safety profile. and the risk versus benefit.
Thank you. Thank you for explaining those differences. And finally, patients post-stroke often live with multiple chronic conditions such as hypertension, diabetes, obesity, and other conditions. What specific hemodynamics should be monitored to improve physical functioning in these patients once they go home after stroke?
So I think most of what the guidelines were addressing as far as hemodynamics were more about the acute phase because there was more clarity around the blood pressure parameters. And this might be good for people who mostly work in a clinical space in an outpatient zone to know if you're in the hospital with a friend or a family member, according to these guidelines, um, they may be living with hypertension, and when they're having a stroke, their blood pressure is in the 200s. Well, we're going to work towards getting it down to like 180, and we're not going to try to get it below 140 because we're going to allow what's called permissive hypertension in order to increase the blood flow to the brain during that time of injury. And there's a real risk to it getting too low. The the what am I trying to say? Like the ground floor of hypotension in that scenario is maybe higher than normal because, like I said, we want to get all the circulation we can to that area that's being starved of oxygen rich blood. Now, for long term stroke prevention, yes, we want to see blood pressures that are staying less than 130 systolic for stroke prevention, but it may take a while to get it to that zone. And something that I like to really encourage patients to do is to take their blood pressure at home when they go. A lot of the patients I've encountered, they didn't know they had high blood pressure, for example, or blood sugar. They're like, I wasn't diabetic till I had that stroke. They were, they just didn't know. Um, and so teaching them about, finding out where their body levels out at home is important because we'll start them on medications in the hospital to address that hypertension, but we don't want it to get too low because that can lead to orthostatic hypotension, which can increase the risk of falls, which, if they're on a blood thinner, can increase their risk of bleeding. So it's really important to find that sweet spot and realize, especially as providers, that we need to educate them on finding that sweet spot. And it's not just take your medicine every day, but find out if your medicine is getting you to the safe zone or if it's taking you too low, or if it's not getting you low enough. And so we have all these great tools for like remote patient monitoring that will let us see into their lives, but also just showing them and educating them to look at it for themselves. What numbers are my safe zone that I'm working towards, and it's not just to take this regimen of medicines every day without checking up on it.
Like I tell my patients every day, they have to participate too. We can give them the tools, but they're also part and parcel of the outcomes for sure.
Yeah, definitely.
So, is there anything else that these new guidelines that were recently released, is there anything else that you think is really important for our audience to know?
Um, Going back to, the time is brain and that early recognition, the number one thing that everybody can do, you don't have to be a stroke expert. You don't have to have all these guidelines memorized to actually be the hero who makes the biggest difference. Like I was just speaking with a neurosurgeon a couple days ago about how he's like, I have this great success rate of obtaining the clots out of their brain and pulling it out in the thrombectomy. But if it took them so many hours to get here because they didn't recognize the signs of stroke, or EMS took them hours to get here because they live in that rural area, then there's only so much that restoring that blood flow can do. So I want to really encourage everyone to be familiar with B fast, know the signs of stroke, and when to call 911. B is for balance, a sudden change in balance. E is for eyes, a sudden change in vision. F is for face, like a facial droop on one side. A is for arms, where one arm is weaker than the other. And a sudden one sided weakness is a really clear sign of a big stroke. S is for speech. It could be slurred speech. It could be difficulty getting the right words out. It could be not understanding what's being said to you. And T is for time, where time saved is brain saved. And if anybody is showing these signs of stroke at any age, could be children even, it's actually in the top 10 causes of death in children is stroke. So call 911, and this is my soapbox, but I will not get off of it. Do not ask permission to call 911, because the person experiencing it, their brain is under attack and they may not even know it. So call 911. EMS will determine if they need to go to the ER. So if you think it's a person who, typically wouldn't want to go, they may not be able to make that decision if their blood is not getting to their brain. So that is what I would want to leave everyone with, no matter if you work with stroke patients or not on a daily basis.
Well, Rosa, your passion is obvious, and your knowledge is, spectacular. The way that you explained these questions and offered some insight into the new guidelines. We really appreciate you taking the time today, and applaud you for all that you do. Thank you.
Oh, Kim, it was an honor. It was an honor to be invited by the AANN to represent them here. So I really appreciate us being able to collaborate on this to get the word out.
Yeah, absolutely, and to continue.
Mm-hmm. Definitely. Thank
Thank
you.
you.